I'm Dr. Stuart Drescher. I'm a psychologist here in Salt Lake City and on the board of directors for Offer. I'd like to welcome you this evening. We have a remarkable presentation ahead of us, but first I'd like to allow for a few announcements and then I'll introduce tonight's speaker.
Hi, I'm Bobby Edson, and I want to know if you all know about this, because it's exciting. We are having a patient awareness event called Planting Seeds of Hope, and it's May 17th, and it's going to be awesome. There's going to be a whole lot going on, and it's an open house from 1 to 4. There will be tons of information. Thank you, Linda. Resources to connect with, people to connect with. There'll be refreshments. There's going to be our Offer Boutique, and let's see what else. Pardon? Oh, there's going to be a youth room where they can go and connect with each other off to one side, so that's really nice for them. And there's going to be a drawing. I'm really excited about this because there's some neat things that you could win. So please come.
Thanks, Bobby. And then just one more thing. At the Mind Body Wisdom Center, there is a free restorative yoga class taking place on Wednesdays at 5:30. Right now, it's free. I don't know for how many weeks that's going to be for. I've been myself a few times and have really enjoyed it. It's very much low-key for people on our level. And again, that's at Mind Body Wisdom, which is about 700 East and 77 South. You can find it on the on the Offer Facebook page or on the Mind Body Wisdom Facebook or website for more information. And then on these flyers, we've got extras here tonight. If you have a place that you think there's other people that would see them and be interested, such as your doctor's office, your pharmacy, anywhere like that, feel free to take some extras, pass them to your friends, post them. We'd love to get the word out so everybody can benefit from the resources that will be available. And I'll turn the time over to Dr. Cindy Bateman. Sorry, I'll turn the time over. Yeah, I'll let you do it. Let's do it.
The community that has formed around these illnesses includes subgroups, including those people who have the illness, those people who are treating the illness, the people who are doing the research that hopefully will unlock these illnesses, and the advocacy community. Dr. Lucinda Bateman is a person who has her feet in several of these as she treats people with CFS and fibromyalgia every day. And she conducts the research that is an important aspect of this and is connected to some of the most active people in the United States. While she doesn't have the illness herself, those of us who are thinking about this illness are constantly trying to see it from a larger perspective. And I was talking with Cindy just before the talk tonight, and she was excited by some new perspectives that she's recently been able to synthesize. And so tonight we're going to have not only a report on the research from the international conference in San Francisco that happened just recently, but also the latest in our own thinking. Dr. Lucinda Bateman.
I can figure out the right glasses to wear. watch myself on these videos, and all I do is play with my glasses in the whole video thing, so hopefully I can avoid that. Yeah, I was talking to Stuart before this started, and there have been some things that have really helped me in the last while to just move my thinking forward. And I don't mean to say that I'm thinking of these things before other people, but for my own self, I think that the picture is coming together. I don't know if anybody remembers a long time ago at one of these conferences, I used the analogy of a puzzle and put the photograph of puzzle pieces up on the board, talking about how we have little pieces of the puzzle, and we need to start doing this really big puzzle, and the pieces start coming together slowly, and at first it doesn't make any sense, right, what the picture is, but as more pieces get put in the puzzle, you can start to see what the picture is, and you can move faster and faster until pretty soon you're picking up speed toward the end. So the things that have happened to me in the last while, one is I got asked or invited to be on the Institute of Medicine committee, or the IOM committee that is tasked with reviewing the literature and trying to update or come up with a better case definition and maybe a name. You can read the task of the IOM. It's been a great opportunity to be around really smart people and people who are really good at what they do, coming together to try to solve a problem that no one's been able to solve. So it's really helped get my mind cranking to read like 200 abstracts and try to summarize them and present them to this group of really smart people. And it's got my brain primed, and in the meantime, I had to prepare some things to take to this conference. I don't have the initial slide up there, but the IACFS ME Scientific Conference. This is a conference held every 2 years. It's put together by a loose group of people who, in the field, professionals, researchers, and clinicians who have formed a nonprofit so that we can have some cohesiveness and come together to kind of present our research. The ICFS is not a wealthy organization. It's not like the American Heart Association or the American Cancer Association. They're an organization with barely a structure and barely a budget, and people who, in addition to their very busy careers and lives, try to do something more to move the field forward. And it's hard. It's really hard to plan an international conference and bring people from all over the world and have them, gauge and time their research to come and present. So anyway, and I was on that board once, so I really have an inside view of what it's like to function in an organization like that. And everybody on the board of Offer knows what it's like to try to do things and move things forward when you don't have energy or you don't have money or you don't have staff, and to try to come together and bring people with different ideas and move things forward. So I love this conference. I've gone to it for many, many years, and in the 2 years between conferences, quite a bit can happen. And sometimes what gets presented at the conference from researchers all over the world, sometimes it earth-shattering, sometimes the research doesn't go anywhere, and sometimes it starts to put a puzzle piece in and connect the dots. And it takes usually a little while for those papers to be published, so they tend to be published over the next year, sometime before the next conference. So it was after this conference when I made the commitment. Well, the conference was wonderful, actually, and lots of things happened in my brain to start to make connections and put those puzzle pieces together. And one of the things I did was gave a talk on fibromyalgia in the patient conference. And honestly, the two speakers who came to talk about fibromyalgia, do I dare say this, were kind of an afterthought, because this is a chronic fatigue syndrome conference. And these fields have grown up in separate silos without a lot of overlap, and it creates some confusion. And I'm not meaning to say they're the same thing, but there's a lot of, it's probably not a good way to separate illnesses, is by fatigue and pain. So when we use those to separate illnesses, it creates confusion. And they were trying to raise money for this conference, and one of the ways you can do that is to get pharmaceuticals to donate money, but they can't donate to something if the disease that their drug is for is not on the program. So unspoken pharmaceutical company was more willing to donate money to the conference if fibromyalgia was on the conference. So they asked me to come speak about fibromyalgia because I'm an insider and I would be safe, right, as a chronic fatigue syndrome researcher to talk about fibromyalgia. And then they brought a researcher from Stanford whose name was Jared Younger. And it was an incredible opportunity to speak next to him. Because I talked about comparison of the case definitions, and he got up and talked about the research and the overlap. So I'm going to share some of that with you. And that was in the patient conference. So things were distilling, and I thought I would prepare for this because I made a commitment to come and summarize the interesting things at this conference because I would be there to the whole thing and I could take notes. But as I prepared for this, I realized I didn't want to create another summary of this conference. I want to talk to you about what I learned at the conference. And I'd like to bring together some things from the past, present, and future to talk about some ideas. So the first slide really is just summarizing. I'll do a little bit of summarizing about the conference, and that is really the top themes of this large, many-day conference were that studies are getting bigger. The studies that are getting published in this field now have hundreds and sometimes 1,000 or more people in the study, which really strengthens the study. There's more scientific rigor. That means people are doing better studies, controlled studies, studies that are considered will be more respected. And there are large databases being gathered. That means people's blood and data are being saved in numerous places so that other researchers can access those samples who don't have access to patients, like the Stevens Association Biobank, which kind of was a pioneer, but now they've been eclipsed really by, I would say eclipsed, but fast behind them, Stanford has a huge growing database. Columbia University has a huge growing database. So there are these, and the CDC is developing a big database, and that is going to provide very fertile ground for other researchers to come and compare data on the same patients. So, and then I just put some of the really major institutions up there. In addition to all the regulars who've been around a long time, there was really a heavy presence from Stanford, Columbia, Harvard, Johns Hopkins, Institute of Medicine, Centers for Disease Control, everyone there, not just watching in the back, participating, being part of it, interfacing. That's huge. If we could have 10 years ago wished for something, we couldn't have dreamed of this at that point. So this is really great, and it's going to lay the foundation for us to move forward. The other highlights, I think, of the conference were brain studies, because the conference was held in San Francisco, and one of the major conference planners was Lily Chu, who went to Stanford. She's a physician who has chronic fatigue syndrome. And Jose Montoya, Dr. Montoya, is an infectious disease doctor at Stanford. And miracle of miracles, they arranged an all-day symposium for doctors and clinicians at Stanford the day before the ICFS ME conference. So they were able to highlight for the rest of Stanford the research they've been doing in their clinic, and it was filled to overflowing. They had to move it to a new room. That is really great. Ron Davis at Stanford is doing whole gene sequencing. That means, this is an amazing and extensive process where they take the whole genome and analyze it by computer and compare how the number of types of genes compare to other chronic illnesses to see if it gives us clues to what might be the underpinnings. There were great data presented on cytokines, and there were great data on cardiopulmonary exercise testing that really validate and substantiate what we know about that, showing that people are ill. And then I wanted to talk to you a little bit about focus on Utah, and I'm going to start with that. I think it's okay to address questions if you want while we're going through. We do have a lot to cover, and we can do time for questions at the end as well. So I wanted to tell you just a little bit, since we're all from Utah and sitting here in Utah, I wanted to talk to you about our representation there. The Chronic Fatigue Initiative is a big, it's a nonprofit centered in New York that has a multi-site study and have been recruiting people from 5 sites in the country, storing their blood in a biobank at Duke, and they're planning to do grants and continue to do studies. And we're one of the sites, 40 patients and 40 controls out of all the sites. All this blood went to Columbia for a massive pathogen study. Bottom line is they haven't found anything yet, looking in the blood. But that's interesting. But that parallels what we already know about the illness. What they did see were really interesting cytokine signatures. That means the inflammatory process and the immune system evidence around, and you can begin to draw some clues about what that might mean. We'll talk about that. And so they're going to shift their focus a little bit to that. They do want to do more investigations for pathogens in organs, if they can, but it's very expensive. And it's hard to get organs or organ tissue from people. It's much easier to get blood and urine from volunteers. But they also are very interested in looking at the microbiome in the gastrointestinal tract. So they're actually going to do another phase of that study where they collect more samples and do additional testing to see if they can understand how the microbiome might impact disease and change in the body. So that is very exciting. I was able to present a poster, just some of the summary data from this study about the high incidence of thyroid disease in our patients. More than 30% of people who fall under the umbrella of chronic fatigue syndrome end up with hypothyroidism as a diagnosis. Some of that may be from being people put on thyroid when they don't really have a thyroid problem, but probably it's more than can be explained. We also did a study that was part of the CFI funding that we called the EPI study, and it was supported by each of the doctors at 4 different sites who are CFS specialists. We got a bit of money for research interns, and they spent the summer in 2012 pulling charts, calling patients who'd been sick for more than 10 years, or approximately 10 years. Between our 4 sites, we pulled the charts of something like 1,500 patients, and we actually completed phone call interviews with almost 1,000 patients to ask them very basic information about how their illness progressed. And then we presented this data at the conference. Probably one of the, we were able to get an epidemiologist at Columbia to crunch and analyze our data and help come present it at the conference. Then the CDC has been doing a multi-site clinical assessment of chronic fatigue syndrome, and our site is also part of that. And they've gone two years of data collection, and there'll be a 3rd year data collection. So Utah participants are really actively involved in some of the most major studies right now that are going to hopefully help them move the field forward. And OFFER also played a role in helping contribute to the conference. They funded a college student, Nicole Baldwin, who came and spent 3 months in my office last year as a research and clinical intern. Both of her parents are doctors. Her dad has chronic fatigue syndrome. He's disabled. He was a general surgeon in the height of his career. And Nicole spent time, I think it was just amazing, did a project that I set up for her, submitted it, and was asked to give an oral presentation at the conference. There were only 4 presentations on treatment, and the other 3 were on non-drug treatments. So Nicole, and she did an amazing job and earned the respect of all the researchers in the country giving her presentation. And Megan Sandy, who works in my office, gave her some money to help facilitate what's a pretty expensive trip to stay in a hotel for 4 or 5 days, travel to San Francisco, and pay the conference fees. And that's OFFER's effort to educate more medical providers so we can expand the reach of people in medicine. So I don't want to summarize the conference, but I am going to tell you, and this talk will be posted on our website, that I've listed here online summaries of the whole conference. If you want to go online and read different summaries of the conference. They're all slightly different, a little bit different approach, a little bit different depth and complexity. And the Phoenix Rising site also does the Stanford Symposium, the whole day at the Stanford Symposium. So I would really encourage you to go online and read some of those summaries, and they might make a little more sense to you after hearing today. So how can chronic disabling conditions that affect 5 to 10 million people in this country and cost $20 billion a year, be such a medical mystery in the age of modern medicine. So in my thinking about this illness, I thought, what kind of a problem would fit this scenario? It's a given, right, that this isn't, people aren't making it up, it isn't just a mental health problem, we're past that, right? This is a very debilitating set of problems. What kind of illnesses could possibly be overlooked by our advanced science and medicine? So I started thinking, well, on the right, the illnesses probably would involve the least understood and least developed areas of science and medicine. Viruses, we hardly have any treatment for viruses, and we don't really culture them. We don't have many tests for them. Really, it's only on the forefront of where people die from them. And then we've developed technology in organ transplant and in AIDS patients. But have you ever had a viral culture? Not really, and there aren't very many antiviral drugs. So the next is the immune system. We have pretty much a very rudimentary understanding of the immune system, antibodies, autoantibodies, how the immune system works. The endocrine system, that's hormones. We're pretty good with the very basics of hormones, out will they affect our organs, but we know very little about their origins and what happens where they come from up in the hypothalamus and pituitary. We actually tried to start doing some workup of our patients and discovered that most of the tests in the textbook aren't even done by endocrinologists. And some of them aren't covered by insurance because the cost to do them is more than the insurance will pay the doctor. So the doctor won't order them. So we have some issues, and we're a little behind in understanding the endocrine system. We know very little about the brain in general, what happens there with immunity, inflammation, hormones at that level, cell receptors, neurotransmitters. We know a little bit, but not very much. We are starting to understand genetics, but we honestly don't know very much about the gene, what happens to the gene, and what the gene produces, which is gene expression. And we don't know very much about environmental exposures and nutrition, based on what the potential to know is. Think about it, how it is very, very rudimentary. So we have a chronic multi-system illness, probably somewhere in this realm. And I'm going to argue that actually it might really be in those realms. And I'm going to make a case for it. Well, what about our system? What kind of a system facilitates this problem? Well, it's a system focused on cutting expense. Right now, we're cutting back. We're trying to be more efficient. Research, it's hard to get funding for research, so funding's kind of fallen in two pots. I have big funding, and that's from pharma and from the NIH. So if pharma's not interested in you and the NIH is not interested in you, you can't get studies done. And it's much more difficult to advance science. We also have a focus on evidence-based medicine and practice, and that means we value and teach only well-established facts. Now that's great, but what about new facts? What about the things we don't know yet? How do they find how do they find their way into our textbooks if there's that big gap between a large evidence base and a new idea? There's definitely a low priority given to non-fatal illnesses. The money goes to heart disease, cancer, HIV, and think about it, when XMRV was considered an issue, millions of dollars were poured into it because of its potential relationship to HIV and for the society at large, and as soon as it was proven not to be there, boom, we dropped off the map again. We're too rushed in the clinic, and that creates a situation where it's easy to stereotype, and it's easy to go to to send someone to someone else. So those are the major things that happen in the clinic. Either people jump to conclusions about what's going on, or they turf you off to another specialist. Whatever the illness is, it's not obvious on the standard history and physical exam because doctors have even moved away from doing it. How long has it been since you actually had someone do a whole physical exam when you go into the office? Because it doesn't yield very much. We have such good diagnostic tests that we've kind of stopped doing it. But guess what? We don't have diagnostic tests. All the diagnostic tests we use don't find this illness. So when the insurance, when the tests are done, you don't have something. So all the things that we use are not working, and it doesn't fit neatly into a specialty. So you can see that we have a problem. There's a reason why we've got this profoundly disabling illness that affects millions, that costs millions, and we have not made progress. So I'm going to talk to you about 3 areas that I believe fit in this situation. The first one we're going to talk about is autoimmunity. The second area we're going to talk about is the brain, and a little bit about inflammation/immune. What happens, how does your immune system and inflammatory system, how does your brain defend itself from injury? And also, how does your brain control your hormones? So we'll just lump that under brain. And the third is the autonomic nervous system. And the autonomic nervous system is what runs your body when you're not thinking, runs all your organs, your blood pressure, your pulse, the way your eyes focus. We'll talk about it. So if you kind of draw a blank when I say this, that's my point, right? This is the area where common people don't know very much, and actually none of us know very much, even doctors. So let's talk about the first area first. Autoimmune diseases are diseases where benign autoimmunity, or that safe autoimmunity, changes to pathogenic autoimmunity. So your immune system has the capability of turning on anything, but there are checks and balances that keep it not attacking yourself and directed toward attacking intruders. So if you develop an autoimmune disease, something's happened to disturb that normal balance. And in general, we look for antibodies and T lymphocytes, and that's how we prove an autoimmune disease. So antibodies are the things proteins your body forms against that to recognize it. They coat the invader, and then your T lymphocytes and natural killer cells and other things come and chew it up and try to kill it, whatever it is, a bacterial infection, a viral infection, or an injury if it's your inflammatory system. But actually, this is not the system that works in your nervous system. It's all encapsulated. It doesn't have these cells. It kind of does, running through the fluid, but not exactly. So we want to think about autoimmunity. So these are the autoimmune diseases. We think of lupus, and lupus actually can attack any organ in your body. Look at that. Joints, blood, skin, liver, kidney, heart. It's because it's antibodies directed against the nucleus of a cell. And it tends to be attracted to certain types of cells, and then your immune system will gather and cause inflammation in a certain organ. So when I was in medical school, we learned about multi-system illness. It was kind of a new thought. It was taught by a wonderful woman named Mary Betty Stevens, who was a senior faculty member when I went to medical school, about this concept that eluded us so far, about the idea that an illness could affect your whole body and be unmeasurable. Does that sound familiar? And then we learned about measuring antibodies and being able to measure the immune system, and then we look for damage in those organs, and voila, that's how you make a diagnosis of lupus. There are actually now more than 80 autoimmune diseases known in humans. And I've just listed categories there of glands. It's called Sjogren's syndrome. I'm not going to go through them all, or pancreas, or thyroid. There is an autoimmune illness for almost every organ in your body that we have learned how to identify to some degree. And if you look down at the bottom, we've got the peripheral nervous system. That's like the nerves that go out to your limbs. We know about peripheral neuropathies. They're not all autoimmune, but we do know of some. And autonomic neuropathies. And myasthenia gravis is an autoimmune attack on the end, between the end of the nerve and the muscle, right where the nerve comes to the muscle at the neuromuscular junction. But honestly, there's no autoimmune diseases in the central nervous system on that list. The thing that comes closest are illnesses that we say we don't know for sure what the cause is. We think we know there's destruction. Parkinson's, MS, narcolepsy, certain kinds of dementia, and we know that there's destruction in the brain. We're not sure why. We've got some clues we haven't really identified, but I want to just raise that thought. Now at the conference, where is it? Dr. Noel Rose came at the ICFS conference, came from Johns Hopkins. I'm pretty sure, I could have this wrong, but I'm pretty sure he's 84 years old. And talk about a luminary. This is a man whose career has spanned the discovery of autoimmune diseases, and he is the chief and head of the Johns Hopkins Autoimmune Center, or Center for Immunity. And he gave a perspective talk at our conference about how do you recognize an autoimmune disease? And it was fascinating. And the first thing he said was, oops, oh yeah, where is it? Okay, so on the left, this is a quote from him. Well, I took the same quote and took out the words autoimmune disease and put ME/CFS/FM in the blanks. And it exactly describes our illness. It can strike any part of the body, the symptoms vary widely, the diagnosis and treatment are difficult, that problem goes to multiple specialists based on which organ is affected, and people see multiple specialists. And this compartmentalization has hampered communication among physicians and scientists who might be interested. Does that sound familiar? Okay, so I'm going to go down a little path. And Dr. Rose said he was going to tell us how you can tell if something is likely to be an autoimmune disease. But he said, there's several levels of evidence. One is direct evidence, one is indirect, and one is circumstantial. It's how strong the argument is. Now, direct evidence means we've identified the antibodies, and if you take them out and put them in something healthy, it gives that the disease. And we know that in myasthenia gravis and Graves' disease because of a baby that's in utero or with the mother. I'm not exactly sure if it's during the pregnancy or right after, but the antibodies can be transferred to the mother, and for a period of time, the baby suffers from those antibodies until they all die off. So we know that the antibodies from the mother can make the baby sick, but the baby doesn't have the disease. So that's direct evidence of an autoimmune disease. Indirect means you could create something like it in test animals. And circumstantial means, gosh, there are lots of things that look like an autoimmune disease, but we don't have proof. So I'm going to make an argument that we meet the criteria of circumstantial evidence for an autoimmune disease. And from his talk, Dr. Rose's talk, he said autoimmune diseases typically have features of environmental issues, genetic issues, endocrine issues, and then a list of other things. So the environmental factors might be this. Well, let's put it to us. Environmental factors. Viruses. Do we have viruses in our equation? Yeah, lots of them actually, that are suspected to be triggers for this illness. Bacteria, yes. Stress. Stress is high on the list. Pollutants. How many times does pollutants come up as a question for starting this illness? So our illness complex definitely has a history and suspicion of environmental factors triggering the illness. How about genetic factors? Do we have genetic factors? He said this is an important feature, checklist for autoimmune illnesses. Let's see if we do. Do other autoimmune illnesses happen to people with our illnesses? Well, I thought of three right off. Hashimoto's thyroiditis, celiac disease, and Sjogren's, which is dry mouth, Sicca syndrome. It's kind of hard to tell with illnesses if people with that illness have fatigue or if people with our illness get that autoimmune disease. So keep that in mind. What about twin studies? If you studied identical twins, if there's a genetic predisposition to this illness, it should be more common in the identical twins than fraternal twins, which are actually just siblings. So actually there are a lot of studies in chronic fatigue syndrome. The first one was in 2001. And when they looked at identical twins, 55% of the other both twins had CFS, and only 19% if they were fraternal twins. That's a pretty big difference. And there's actually, Dr. Buchwald also did a study in fibromyalgia, and it was 34% in the identical twins and only 4% that they both had fibromyalgia in the siblings. So that's very strong evidence there's a genetic predisposition for our illnesses. Plus, one of the best papers published in this area was done here at the University of Utah by Lisa Cannon Albright and her husband, Albright. They used a database and looked at thousands of discharge summaries. They used the family history database, and they could show a relative risk of 2.7 times in first degree relatives. It got to be 2.3 times and 1.9 times by third degree relatives with a very high p-value, which is the likelihood that it's a true result. And everybody quotes this article. So that we have really strong evidence for genetic predisposition. In addition, there are illnesses that have what we call HLA, human lymphocyte antigen. It's sort of a marker on cells that come from genes that determine immunity. And diseases like autoimmune diseases that are rheumatologic, like lupus, ankylosing spondylitis, rheumatoid arthritis, multiple sclerosis, and narcolepsy, all they have a certain kind of gene, a certain kind of receptor that comes from those genes that you can measure in the blood. Well, gosh, those are like the major diseases that we confuse with our illness. If you think about it, those are, I called it a soft boundary in trying to diagnose. So they have a lot of similarities to us, but actually some studies have been done in people with CFS that show that there are HLA alleles or that kind of a genetic link. Now, whether it's from crossover with those other illnesses, whether it's part of our illness, is what it becomes difficult to know for sure. But I think that if you lump fibromyalgia in with ME/CFS, then you have less chance of confusing it with another illness because we have pretty good markers for other illnesses. Okay, the third one is autoimmune diseases occur more frequently in women. You've heard that before. That's really the case. And is that the case in our illness? Well, actually, it is. Almost every study shows female predominance over men. And the men who have these illnesses tend to have low testosterone, which may remove some of the protection that men have who have higher testosterone. So that is one of the differences between men and women. And the most common time of onset is during teenage and during menopause of this illness, when hormones are abnormal and deficient. Areas of the brain don't have good blood flow, that there's problems with serotonin and dopamine, and there's inflammation in the thalamus and amygdala. Remember, that's in the center. I'm going to show you some pictures, so kind of remember those words. And a problem with serotonin binding. Aren't these words that sound a little familiar to us about drugs we use? And he talked about a study they did where they were able to label a protein on the surface of glial cells. So they injected that protein in people, lit up their glial cells, and then did PET scans. And they were able to show multiple areas in the brain that were inflamed in CFS patients based on this labeling of glial cells. It was a small study, but very, very intriguing. And the degree of inflammation correlated with how tired and sick they were. So that correlation is interesting. Another presentation at the conference that related to the brain was by Marcy Zinn, who is a PhD in neuroscience, I think. I don't know her background. But she presented information using quantitative EEG. They did a very good study, 50 patients, 50 controls. I think the patients were not on medications, if I remember that. And they were able, quantitative EEG, EEG is like brain waves, right? And the different frequency of brainwaves tells us how alert and awake we are. And these are changes, what they saw, I'm going to put these in a different order, was a reduction in peak alpha frequency. Now this is a finding studied in neurocognitive research, people who study cognition in the psychological field. And when it's abnormal, it's seen in head injuries, or something that causes dysregulation of the pathways between the cortex and the thalamus, which is the center part of your brain. And I just put this up for a diagram. That big peak is your alpha peak, and a reduced alpha wave frequency would mean it's slightly shifted to the left, because that's a frequency scale on the bottom about how short and quick and it's, I think they generate this, a computer generates from all the waves and gives you a summary. So it's very accurate because it's taken from many, many, many brain waves. And they found reduced alpha wave frequency in 50%, more than 50% of the cerebral cortex, which is the whole frontal area and the sides. That's a little bit troubling. And alpha waves are the relaxed awake waves, and if they were reduced, you'd be just a little more flat cognitively and not quite as awake. I don't know who he is. He has her same name. I think he might be her son, but I'm not sure. His name is Mark Zinn. He presented EEG data, a little different, that showed that delta waves were increased in the frontal and limbic areas. So the frontal is the front, and the limbic is the next layer down. Delta waves are slow waves. Delta waves are present when you're asleep. So there's more slowing, more asleep waves, and the rapid awake have been altered as well. And he said, these areas are consistent with sensory ataxia. That means kind of discoordinated feeling of sensory signals like pain and fatigue. Reduced proprioception, that's not knowing where you are in your balance. Slow motor performance, moving more slowly. Pain, hypersensitivity, deficient verbal working memory. Limbic encephalitis and global CNS hypoactivation. He said it looks like a limbic encephalitis. That means the mid part, the second layer down of your brain, looks inflamed, and it causes global slowing of your whole brain. What does that sound like?
Oh.
Wow. So, and they did that on the same patients, 50 patients and 50 controls, the same sample. So I pulled back in the literature, and actually there was a paper published 2 conferences ago in 2010. It was not a bad study done at Harvard that really kind of got overlooked because nobody was doing EEGs. This was a big study, 390 health controls, 70 CFS patients, 24 with major depressive disorder, and 148 with just fatigue. They came in, they did another kind of EEG, quantitative mathematical analysis, and came up with a formula, and they could predict who the patients were every time based on this formula. And it was the temporal lobe, which is these areas of the brain. Sounding like a recurrent theme. And you know, the literature has said cognitive impairment, positive Romberg, that's being wobbly when you stand, all kinds of dizziness, and we have a history in the literature of scans, but nobody ever did big studies. So, you know, SPECT scans have been abnormal with the way blood flow, MRI scans, people have more spots on their MRI. Well, spots are areas that had been damaged, little tiny damage areas in the brain. And PET scans showed reduced metabolism in the right frontal cortex. They're not very big studies, but when you go back in hindsight and match them with the big study, it's starting to create a picture that looks like there's something going on in the brain. This is a guy who presented from Stanford MRI findings, and his MRI, I didn't hear this talk, so I had to kind of shorten it, but decreased white matter. Now, what gray matter is the outside, right? Your gray matter is where you think, and the white matter is the next layer, and reduced volume of the thalamus, which is part of the white matter. So let's just look at a picture here. The left would be the front part of the brain, the forehead, the frontal cortex. And then the next layer down would be the limbic area. That yellow area is the, what do they call that? Anyway, that's where the thalamus and hypothalamus, the most core area of the brain that come down, turn into what we call the brainstem, and then it turns into spinal cord. I want you to kind of remember these areas of the brain while we move forward. So this is another view of the brain. Okay, here's the brain. Now what I did is I lit up, this is a brain that shows where the fluid is in your brain. The blue, this is fluid circulating in your brain through, this is where your spinal fluid goes around in your brain. That's kind of interesting. That's right by all those areas right there. And I don't know if you can see where the pituitary is. The pituitary is that little teeny bag that hangs down at the base of the blue. See how the blue comes down to a point, and then there's a little punching bag there? That is your pituitary. I went back in the literature, and actually Dr. Van Nadelson did a study of spinal fluid. And in that study, it was published in 2005, there was protein in the spinal fluid of patients with ME/CFS, and they also had some cytokines that were higher in the spinal fluid. And they said, we think that some patients with CFS have neurologic abnormalities, and that immune dysregulation within the central nervous system might be the cause. That was a little while ago. That was a good study. And I just put this slide up because these are the proteins in spinal fluid. They're also the proteins in blood. But the ones on the bottom are your immunoglobulins. So the yellow, fibrinogen, immunoglobulins, and C-reactive protein. You've heard of a CRP. So those are reflections of inflammation and immunity in a solution, and this would be in your spinal fluid. So now let's go inward. So we talked a little bit about the cerebrum, frontal and the front and the side. Then if you go in to the core, can you see that pink, green, and blue core inside the brain? We've removed it in this picture. We pulled it out so you can look at it. And at the two arrows point to the hypothalamus. Actually, the hypothalamus isn't labeled in this picture, so I put an arrow there. It's like those arms wrapped around, and they come right down to the pituitary, which is the second one. And above that is the thalamus. And so these are coming downstream from the upper part of the brain, and this is the inner part, the white matter of the brain that they talked about in those scans. Let's talk about neuroendocrine. So first we were talking about inflammation. Well, what if that inflammation came down to the area where all of your hormones originate, in the hypothalamus and the pituitary? Well, this is a list of the hormones from the pituitary. It's too small to read, but I'm going to go through it. And the pituitary is divided into the back and the front, the posterior and the anterior pituitary. And there are two important hormones from the posterior, and we just got 6 listed there on the bottom. And I put red check marks by the ones that have some evidence related to our illness. Some piece of evidence, circumstantial evidence, that there might be a deficiency or a problem there. And we'll go through them briefly. So we know that there's low corticotropin releasing hormone, a pretty good study, and that is the stimulus from the hypothalamus to the pituitary to release cortisol, to release ACTH. Then those 6 hormones from the anterior pituitary, we know that growth hormone is low, particularly in fibromyalgia patients. We know there's thyroid problems, right? We can't put our finger on it. Well, if you don't get the signal from above, you don't have the normal way of measuring if you're low in thyroid. And our tests are variable for looking at thyroid hormones. And I presented that paper before I started all this, that there's a lot of hypothyroidism, that eventually at least a third of our patients are placed on thyroid hormone. What about those hormones, FSH and LH, that go down to testicles and ovaries? Do you think there are any problems with that in our patients? Well, actually, there was a good study published by the CDC that showed that almost every gynecologic problem is higher in people with CFS than other people. And a good study. We also know that symptoms tend to be better in pregnancy when all the hormones go up, and it's really bad afterwards when they crash back down to the base level without all that extra hormone coming. And hormone replacement therapy tends to help a lot of people, kind of lift them up and have a lot of parallel to their symptoms. What about the posterior pituitary? 2 hormones we don't talk about very much. Vasopressin. Vasopressin helps you retain water and constrict your blood vessels. If you didn't have it, you'd have low blood pressure and low blood volume. Does that sound familiar? And oxytocin is one of those, it's usually produced only around the time of delivery, but we don't really know much about it. It's kind of interesting right now, people are taking it to feel better. But in the literature it says if you don't have adequate oxytocin and you actually have oxytocin deficiency, then you're prone to depression, anxiety, social isolation, phobias, panic attacks, sleep difficulties, and other common related stress elements. In other words, you're not very vigorous for stress. So that's that neuroendocrine side. That sounds very familiar. Now, nothing's wiped out. If there's inflammation, it's not vigorous. So there's trickle down. Things work, but they don't work like they should. And they might be kind of hard to measure because they're not absent. Parallel to that is your sympathetic nervous system. It starts in the hypothalamus, and then it comes down, and the autonomic nervous system comes through the brainstem, the tracts, and you have a balance of what's called the parasympathetic and the sympathetic. And if you look on the left, there are those little cluster of dots just below the brain. Do you see those black dots? Just below the brain, right at the neck. And those go out. Those are the first places where the sympathetic neurons come out and start to do things. The first one constricts your pupil. The next one stimulates saliva. And the next one slows your heart rate. What happens if you didn't have enough parasympathetic discharge? You'd have trouble focusing your eyes, you'd have dry mouth, and your heart would race. okay? You can go all the way down, but what's really interesting is all the things that where those neurons come out of the brain and into the spinal cord, they exit way up there at the neck and go do all that stuff. They are right in the proximity of the cells we're talking about, near the inflammation in the brain, just downstream from them. Then the sympathetic part of your autonomic nervous system, most of the ganglia come out on the right. They come out of your spinal cord along in your back, along the spinal cord, and they go and do the opposing thing, like dilate your pupil and inhibit saliva and accelerate your heart. And in most of the studies that we've done in fibromyalgia, guess what? There's a little imbalance called sympathetic overdrive. And there's a little too much sympathetic and not enough parasympathetic. And it's one reason why people have arrhythmias and racing heart, and they can't go to sleep. Because when they lie down to try to sleep, the adrenaline is still there, and it's not shifting back. The parasympathetic is what helps you relax, go to sleep, digest your food. So you can see that it really explains a lot of symptoms in people with ME/CFS to have a slight imbalance of parasympathetic and sympathetic nervous system. One thing that helps understand why there might be an imbalance, and this is getting beyond my pay grade, but the adrenal gland also produces adrenaline. Norepinephrine comes down through the nerves and the nerve endings into the organs, like the ones that dilate the blood vessels in people with POTS, and there may be a problem with antibodies there. They respond to treatment. I'll go into that. But if your adrenal gland squirts out adrenaline, then it can overwhelm the lack of functioning coming down through the neurons of the autonomic nervous system, because the norepinephrine has to come through the wiring, and then epinephrine, or the adrenaline, goes through the wiring and comes out of the adrenal gland. Does that make sense? So if there's a problem with the wiring, you can still pump out the adrenaline or epinephrine, and that's maybe why there's an imbalance. So still it comes back to a traffic jam up here in the brain. See how we're doing here. Gotta stop. Almost done. I think I will go past this, but this is a diagram that explains how orthostatic hypotension works in these pathways, and how a disruption in these pathways might cause orthostatic hypotension. If you have these two theories, there'd actually be two kinds. The kinds with antibodies out in the bloodstream, like kids with POTS, and orthostatic intolerance that may come from a problem up in the brainstem from inflammation in the brain. So why consider the brain? Well, because neuroinflammation in the brain, which is sort of the equivalent of autoimmunity, and we know microglia are activated, would cause this cascade from the core of your brain up into the cortex, via the thalamus, hypothalamus, and down through the autonomic nervous system, and into the whole hormonal axis down to all those organs. And guess what it could cause? Sensory problems, fatigue, pain, cognitive issues, immune problems, and sleep disruption. So it's not a bad theory, actually. So I think we have enough data to describe at least two subsets of people who fit in the criteria of ME/CFS. One subset of people who get post-viral autoimmune antibodies to their blood vessels, to the alpha and beta receptors, they get POTS, and that is exactly what we see in the kids. They don't have that much cognitive stuff. They just can't sleep. They have orthostatic intolerance. They have anxiety. That means their heart races from their adrenaline, and then they get anxiety from real. They get deconditioned. They probably get a lot of weird adaptation to this. They get pain amplification. What causes pain amplification? Stress and disturbed sleep. How do we treat fibro? Reduce stress and improve sleep. And then they get all the secondary stuff, right? Because nobody believes them, they can't do anything, they go to school, and then it becomes this horrible, big, vicious circle. This is hypothetical, but I think it fits really well. The second is, what if you get an autoimmune insult centrally and develop inflammation in those areas of the brain? You would have fatigue. This is the other group of patients I see. People have devastating change in function, cognitive impairment, more vague autonomic stuff, pain, fatigue, dysregulated sleep, and then they get the weird secondary things. Oh, neuroendocrine insufficiency, we talked about those. Deconditioning, because they can't do anything. Then they get weird chronic adaptation of all their systems, and they have secondary you have secondary mood behavioral symptoms. And we did a study, we presented from the EPI study, when we called 1,000 patients and asked them what worked, guess what they said? Learning to live with their illness. Sleep, pacing, and learning how to adjust to all of this. It's like nobody can help, right? You've got to end up doing it yourself and adapting to the illness. And the second most commonly listed intervention that was helpful were medications, because medications allow you to do self-management, to sleep better, control your pain. So anyway, I think that's the end of my slides. What I wanted to say is I think the pieces of the puzzle are getting lots better. What we don't have are big studies. We haven't had big studies because people didn't have a cohesive hypothesis. I think our hypothesis is getting better. And if anybody wants to do anything, it's volunteer for research and help get funding for these key areas to do more study of the brain, the neuroendocrine system, and what would be the equivalent of autoimmunity and autoimmunity peripherally, like the kids with POTS. I think we can answer that. I think we could start, working on all these kids with post-viral POTS right away. And they don't have to have stigma and problems anymore because we can diagnose their illness better. Anyway, so time's gone on. I thought what I would do is entertain some questions and we'll see where to go from there. Is that cool or what? Are you blown away? It took my brain a lot to put those pieces of the puzzle together. I think a lot of people know that, but it took me a while to make sense of it and to sort of put it in one big picture of how it might fit together.
So they talked about leptin and IL-17 being abnormal. So is that something that can be tested for in blood, or they have to do it some other way? I'm looking for some markers or some easy.
Maybe. Almost everything I've listed has the potential to be a marker. The problem is that tests are nonspecific. That means they can be elevated in other related conditions. So we're still in that. At first we're like, prove it's a real illness, right? Now we're in, you know what, this is a lot like illnesses that are similar, and we need to start looking at similarities. And the most similar are autoimmune diseases and neuroinflammatory illnesses. And I don't mean to change anybody, make people worry. You already have what you have, right? What we need is to know more about it. And it should be relief to you, I would hope, to understand that maybe we've got better evidence and we've got something to hold on to, right? And start to move forward. And I'm hoping that what's been done at Columbia and Harvard and what Nancy Klein's doing in Miami and what they're doing at Stanford, so amazing, is really going to create a base that's going to make people interested in coming into the field and funding science.
Sounds like any breakthroughs here, at least piloted, if not curative, would apply to MS and PD and some other things as well.
Exactly. So whatever we learn about glial cells and about measuring it and imaging it and understanding what those connections are and finding better ways to analyze what's happening to those cells, will all the related illnesses have the chance to benefit. I just want to take a step back and say inflammation in the brain can happen from multiple insults, from trauma, from chemical exposures, from virus, from your own autoimmune inflammation. So it doesn't really tell us what the insult is, but we don't know what the insult is in any of those diseases, right? That doesn't mean we can't image, diagnose, and start to develop treatments. I saw a hand and then I'll come back.
Do your discoveries influence how you interface with patients now in different ways?
I had them, so her question was, do my discoveries change how I interface with patients? This very morning, I had a freshman in college and her mother come in to my office. And I think I've tracked them for several years. She got post-viral POTS when she was in high school. She is on the debate team in college. They just went to nationals. She's a great kid. And she has been the most mature and adaptive person I've ever met with this illness. Just calm, just accepts, does whatever, finds the good things that work, moves past the things that are maladaptive. I mean, how could you ask for that? None of us could do that very well. And she's been able to go on and go to college, and she came in a full about to crash flare because the debate team went to nationals. They were doing 8 hours a day and 12 hours on weekends. And she was like, you know, being held together by all the supportive care and everything we were giving her. Fortunately, she's got a break now. But it was like changing her life to have her mother and her and me sit there, the three people who really know she's sick, to explain that I think we have a mechanism for everything that's happening to her. And what was happening was she was feeling discouraged, right? She was getting a relapse and she was really tearing up and starting to feel overwhelmed. And what that did was she was able to walk away from there with renewed strength to go back and do her pacing and do all the things she needed to do. So the answer is, yeah. Because will it immediately change what we do? Well, we don't really have the diagnostic test yet, but what it did is validate the things that we do that work. Because everything that works, now there's, oh, no wonder why that works, right? So it's putting the pieces in about the things that work and things that don't, that will give us strength, you know, give us a lot of power to move toward the ones that have a mechanism to explain them.
Like all illnesses, there is, I imagine, some material, physical, organic cause and effect relationship, causal relationship. But in this, isn't it also true that if you take control of your life and you have healthy relationships, optimistic outlook, constructive, pleasurable activity, that the disease is less than if you were pessimistic and depressed?
Yes, I mean, just think about, there's some things we actually know, and this is what's been annoying about this illness, but we've had to accept it. And that is stress and sleep deprivation and running yourself down. All those things make this illness worse. And in the beginning, I think the predisposition to this may be that your immune system is compromised because of something. There's a little bit of genetic predisposition, and then people are burning the candle, and then they get some virus, and because either their genetics are bad luck, or because they were run down or kept going, who knows? So what I say is, to me, information is useful only for what it can do to make things better, right? It doesn't help for judgment. All it matters for is if it improves what's happening. So I think you all know that if you get more sleep and if you're less wound up, so you can imagine, would adding anxiety to what I told you be good? No. To your sympathetic overdrive when everything's like this? No, it wasn't. That's why meditation and things that slow your heart rate and help that sympathetic overdrive come down help you feel better. So while it's not necessarily originating from everyone, it's still an effective intervention. And I think Stuart will would say, I mean, he teaches and is an expert in how to use meditation to calm all those pathways in your body and have that period of respite when your body can feel better. And it's a chicken and the egg problem, because I really have a respect now that you can't just blame it on someone's behaviors or their mood. However, there are people, I believe, who get themselves in this place because they're always on overdrive, but not most people. Those people are easy to treat, actually. So what I would consider more easy to treat milder fibromyalgia, I think mostly is stress related. I get that. If I'm doing too much, if I'm not sleeping, I'm not exercising and driving, I start to get stiff and achy, sort of like the aches and pains of depression, like the Cymbalta ads. And when I rest and reduce my stress and my diet's better and I'm eating better, sleeping better, it all goes away. So there's an overlay of that. There are things that can create hyperalgesia, those pain pathways in your brain and fatigue. Well, guess what? That gets superimposed on the other process because you can't sleep, you have adrenergic overdrive, you hurt all over, and your life falls apart. So if you had like a normal approach to that mentally, it would be a little weird. That comes after how long? Years, right? Of having to make a behavioral adaptation and accepting your illness and getting all of that to calm down and learn how to control things more with your mind. So yes, it's good, and it's better than nothing when we have very little, but hopefully we can move. What I see all this information is the potential for early intervention. My instinct is a huge amount of this illness is lack of early intervention. It's sort of this ship with no rudder, right? Getting worse and worse, and more sleep deprivation and more worry and more impact on the brain from not intervening. And so intervening early and understand what's going on. Imagine having this illness and walking into a doctor's office in the first 6 months and having them say, we know what you have, here's what we do about it. Can you imagine taking those years out of frustration, fear, grief? I think that would be a good health intervention to do that. It could really change the way this illness looks.
So do you think as everything comes together that we'll get better from different new medications or even gene therapy? What do you think is going to help us?
I don't know. Honestly, I would put this in the category of neuroimmune illnesses. Now, it's not going to change how it presents. We know how it presents, so you're not going to turn into one of those. You're not going to suddenly get Alzheimer's. It's not going to become one of those illnesses. I put it in that category, which means it's going to be a challenge, right, to know how to change the course of that. Now, in the first example, I think with those kids with post-viral POTS, that I think maybe a post-viral autoimmune illness, lots of them get better, actually. And I have an adult who had West Nile virus and developed severe POTS and then the whole syndrome. And guess what? His mother has CFS and fibro. And he always was like, until he got West Nile virus. He was a good kid, but I'm sure he was like getting on with my life, until boom, he was totally flattened by it. And he's so smart and so adapted that he's able to continue working by completely compensating the POTS. And then once he did that, he wears full body compression clothing and then he went and worked out. Because if he didn't have POTS, guess what? He could exercise and he overcame his deconditioning. And now, as long as he paces and doesn't go, it's not perfect, but he's able to maintain, and his depression's gone away, and his brain fog, so many things have improved for him because he's highly adapted and he was able to treat the worst part. Now, whether or not he'll get over it, I don't know. But honestly, I don't think he still has West Nile virus, right? He was one of the rare people that developed an immune response to the West Nile virus. So I'll probably publish a paper about him someday. One question up there.
Are there possible treatments?
Yes. We have pretty good treatments for MS. We have pretty good treatments for lots of autoimmune diseases. Not perfect, but there are people nowadays, people walking around that you have no idea have MS. And that have many years of completely suppressed symptoms and good response. I can tell you that there are certain people who go on Ampligen, which is the experimental drug that we use for CFS, who get all better when they're on it over a period of years. Unfortunately, when you withdraw the drug, many of them relapse. So we have things that can treat some people. Now remember, this is going to be a very complex, variable group, maybe depending on the insult, the type of antibodies, where the antibodies attack. They're not even antibodies up in the central nervous system. Now we need all those specialists, right, and scientists to come in and make sense out of it and take it the next step and see if our hypothesis is correct. How would I state it?
Yes, this is my hypothesis.
I think I would probably do it like that last slide. Let me go back to it. Timed out stuff. Which is, I would say that I think the causes are likely chronic autoimmune and or neuroinflammatory changes. I'm sort of leaving it open to central and peripheral. Centered in the brain, involving the hypothalamic HPA axis and or involving the peripheral autonomic nervous system. So I'm trying to lump all those things. It's those areas that I laid out. That's my hypothesis, is that those are the areas involved and that they interplay with each other. I don't think everybody has the exact same presentation, but those areas fit the areas that we have gaps and that have all the clues. Just remember it's a hypothesis, but it was backed by quite a bit of evidence, right? That's what I tried to present for you, is there's actually quite a bit of evidence to support that hypothesis.
I was wondering, because you're finding a lot more of these puzzle pieces and you're seeing things together. Is there anything you'd like to see with future more start to
Yes, so the question was, based on all that, what would I like to see them look into? I'd like to see us develop antibody tests for the kids with POTS. We should be able to do that, I think, quickly and diagnose POTS better. You can't get a tilt table test. You can't, people don't do bedside tests to see if people have POTS. A lot of people don't even know what POTS is. Doctors. It's becoming more common. It ought to be diagnosed and treated by primary care doctors, pediatricians, maybe a little blessing from the cardiologists. Cardiologists don't know how to treat POTS. They send them to me. People up at primary. Now that's changing. And this paper's going to change everything. They're going to go, whoa, now we have evidence of what that might be. So that's an area I think ought to move quickly. We should be able to identify what viruses are likely to do it. We should be able to, there was a study at the conference that showed there are actually some simple diagnostic tests that predict which people are going to go on to get chronic illness after Epstein-Barr virus. Statistically, at least you could do them and see if they are there, right? You could start to get your antenna up. Then I think we need to do a lot more, find accessible imaging and tests to identify people who have a central nervous system neuroinflammation. So we can put you in a category of someone with a real important debilitating illness and start to provide care. Might change everything. We really need to do studies. Like, you can't just say, oh, let's give them this hormone, because everything's interconnected, right? And you could give something and it would shift everything the wrong direction and create some new problem. So we have some work to do, clinical trials that could be done, but really it's about diagnostic studies right now so people can be correctly identified and included in clinical trials and start to look at subgroups of people who have identifiable abnormalities so we can start to make progress.
What could all of us do to know when there's going to be a study and, to volunteer to be in a study? I've got fibro and chronic fatigue and multiple sclerosis, primary progressive, and I'm old. So, I've got a good picture of how and when everything happened and all the other mitigating circumstances. And I would love to be part of a study, but, who knows if I would qualify, but like all of us, if we could, I'm sure everybody in this room would love to get involved in any way they could.
I think my best advice, and her question is, how do you get involved? And my advice is stay informed. Because if you're not if you're not reading and staying up to date, you have no idea what's going on. It's much more interesting now. It used to be just depressing to try to stay informed. It's getting more interesting. I think the research will follow. It's not there, really. There's some, but it needs to be everywhere. So I think I just stay alert. We'll try to use offer to let people know if things come up. And if you know people who have money, they should put it in the right places. Should I talk to them a little bit about offer? Offer is working on some plans to try to move to a new level, our nonprofit, where we can have a more substantial organization that can, I don't know how much we've got plans, there are the plans, but it's all going to take money. And we'd have to raise $1 million to do something like that. We're not talking about $20 here and there. That's all helpful. Any money you've sent has kept us going. But we need to find people who are interested in making a difference. I went past the Ronald McDonald House. Have you been there? It's beautiful. I know someone who's part of that brand new Ronald McDonald House on South Temple. That thing went up so fast, and all these people who had a lot of money threw their money in the pot, and that thing just got built. I can't imagine how much it cost. And I'm like, wait a minute, we need some of those people, right? We need to find those people who want to invest in a place where people can come, get a diagnosis, understand what research is going on, and donate and maybe leverage it in a nonprofit way, because it's hard to fund stuff like this without extra sources of income, either from the feds or through nonprofits or foundations.
I need a good neurologist that is up on MS, and how do I find one? If I were to call your office, would the receptionist say?
I can't answer that. When you get to the place of frustration, that's just everybody's place of frustration, right? We don't understand MS.
I know.
We can't image it very well. Some people respond to treatment, some don't. So it's a place of frustration. So we're all there, and there's no magic answer, and that's our frontier where we need to keep working. So I think it's time. I usually take about 90 minutes. So I'm happy to entertain a few questions. I hope this has energized you. I hope you go on and read some of the summaries of the scientific conference and get involved. You want to come up and talk to me.
Okay.
Thanks, everybody. So.
Thank you.